In the previous section, we have discussed enough on the workup and the diagnosis of tuberculosis and the diagnostic algorithms as per the current guidelines in RNTCP. In this particular section, we are going to discuss on the treatment of tuberculosis, where in this particular video, we'll be discussing only on the basic pharmacology of these drugs. Very important points, not the entire pharmacology, very important points that are relevant to the anti-tubercular drug therapy as a clinician. In the subsequent video, we'll be seeing on the algorithmic approach and also the current RNTCP guidelines that were in place to treat these tuberculosis patients in India. Without wasting much time, let us move on to the treatment or the drugs that are used in tuberculosis. So we all know the drugs has been categorized into two kinds of drugs. One is called the first line drugs and the second line drugs in tuberculosis. Second line drugs are also called as SLDs. These are second line drugs. So first line drugs, we all know the famous HR, ZT and S. Isoniazid, rifampicin, pyrazinamide, ethambutol and streptomycin, right? So these are your famous first line drugs. And second line drugs, you have a lot of drugs. In that I can split into two groups. One is called second line injectable drugs. These are nothing but the aminoglycoside agents. You know, aminoglycosides are never available orally. They are always injectable agents only. Two drugs will come under this group. One is kanamycin. Second one is campryomycin. Even though amikacin was included before, right now, as per the new guidelines, amikacin should not be used as a second line drug. Either use a kanamycin or a campryomycin. That's what the guidelines are telling. Then you have oral drugs, second line oral drugs. These drugs include the newest ones. One is the bedaquiline and second one is the delamanid and the pretomanid. I mean, pretomanid is not yet available in India. Only bedaquiline is as of now available, and delamanid is available in patchy, and it's the government of India is trying to, take this delamanid into the guidelines. But right now, only bedaquiline has been put in the guidelines so far, and pretomanid is not yet available in India as well. Clear? Pretomanid. Then you have the fluoroquinolones, which are again excellent second line drugs. Like among all the second line drugs, fluoroquinolones form one of the core strategies of the second line drugs. And the two fluoroquinolones that we currently use are moxifloxacin and levofloxacin. Ofloxacin is currently outdated. Previously it was there, but currently it's not there. Then you can use drugs like PAS, clofazimine, cycloserine, and thiostazone. So these are also the second line oral drugs. Clear? In this, the most important thing is knowing what are the bacteriostatic drugs and what are the bactericidal drugs. So you all know among the first line drugs, ethambutol is the only bacteriostatic drug. Remaining all the drugs are cidal agents only. Streptomycin, INH, rifampicin, pyrazinamide, all these drugs are cidal. And one more important question they will be asking is which of the drugs act on the intracellular and extracellular bacteria, or something acts only on the intracellular side or something acts only on the extracellular side. Remember, this pyrazinamide is one drug that is very, very effective for intracellular bacteria only, or at least predominantly intracellular bacteria. And this streptomycin is one drug that is effective only for extracellular bacteria, or at least you can tell predominantly effective for extracellular bacteria. Clear? But remaining all the other three drugs like isoniazid, rifampicin and ethambutol are effective for intracellular as well as extracellular bacteria. Clear? Very, very important point. Similarly, what are the static and cidal drugs? Let us see here. Remember, the second line injectable agents are nothing but the aminoglycosides only. So they must be cidal, obviously. Similarly, your newer agents like bedaquiline, delamanid, pretomanid, all these things are cidal agents. Fluoroquinolones, yes, definitely it's cidal agent. Then we have the clofazimine, and the cycloserine, these are also the cidal agents. Clear? But what are the static agents? We have the PAS, we have the thiostazone, and I think I missed one drug in that, that is our famous ethionamide. And this also is going to be a static agent, which means I can draw this blue as bacteriostatic agents. How can I remember this? Very, very simple. Among the second line drugs, you have to tell that this PET group of drugs, we can remember PETs are static. So PET group of drugs are going to be static. P is going to stand for PAS, E stands for ethionamide, and T stands for thioacetazone. Clear? So these are the bacteriostatic drugs. So these are some of the basic things and basic understandings about the drugs that are used in antitubercular therapy. And remember, antitubercular therapy can be called as ATT or they can be called as antitubercular drugs also. Both are just interchangeably used. So if I tell ATT or ATD, so don't get confused. Both are same terminologies only. Clear? So with this basic understanding, let us see why we are going to give this ATTs in combination. What is the reason that we prefer in combination and what are the different effects that we are expecting from an antitubercular agent? So first one is to prevent resistance. So that's the most important thing. So we are trying to prevent resistance and what are the drugs that are helpful in preventing the resistance. And second thing, we wanted something called an early killing. I won't call it a cidal because you might be confused with the cidal and static drugs. I want an early killing. Books will tell you early bactericidal activity, but in this group they would give ethambutol actually. So that's where you get confused. We are talking about, the core idea of telling early killing or early bactericidal activity is the fact that what are the drugs that can rapidly kill the bacteria or at least rapidly stop the proliferation of the bacteria so that the patient becomes non-infectious. Suppose if he's infectious, immediately you have to make him non-infectious as soon as possible because otherwise he might be keeping on transmitting the infection to the community. So what are the drugs that are effective in doing this? That's what we're going to see here. And next, at the same time, we need to know what are the drugs that have sterilizing activity. So what do you mean by sterilizing potential? For example, I told you inside a caseous necrosis, you have a collar of lymphocytes surrounding and you have macrophages inside. At the same time, you're going to have this caseous necrosis in the center, right? So there are a lot of dormant bacteria that are lying inside this epithelioid giant cells, clear? The Langerhans type of giant cells, inside them, there are a lot of dormant and semi-dormant bacteria, which they don't proliferate much at all. They lie dormant for a long time, and at times only they get reactivated. So who's going to kill them? It's very, very difficult to enter the caseous necrosis and kill this non-multiplying bacteria. Very, very, very difficult because majority of the drugs work by the principle of killing a replicating bacteria rather than non-replicating one. So that's what we are going to see here. So what are things that kills the bacteria in the caseous necrosis or the caseation area so that they can kill these dormant bacteria as well. So in this, we can split into the most effective drug or the drugs with highest activity and highest efficacy, drugs with moderate activity and moderate efficacy, drugs with poor activity and poor efficacy. So what are the drugs that prevent the resistance? Only two drugs, that is isoniazid and rifampicin. These are the two drugs that have the highest efficacy for preventing resistance of mycobacteria for antitubercular agents. Moderate efficacy is with ethambutol and streptomycin, and poor activity for preventing resistance is with pyrazinamide. Clear? So this is the order, but you have to remember this isoniazid and rifampicin at least. So what are the drugs that make the patient non-infectious very fast, which means early bactericidal or early proliferation stopping agents? First, always it is INH. That's why INH we prefer as one of the topmost drugs that are very, very helpful for preventing the proliferation of the bacteria and killing the bacteria very rapidly so that they can make the patient non-infectious as soon as possible. INH, very important drug in antitubercular regime. Then moderate efficacy. Moderate efficacy is with ethambutol and rifampicin, and poor activity is for streptomycin and pyrazinamide. Clear? So they don't cause rapid killing and that early bactericidal activity that much. Even though you might be confused that why I'm mentioning ethambutol here, you might ask me, sir, it's not cidal, it's a static drug. But the goal, what we are talking here, is something different and not the actual static and the cidal war you are going to encounter here. So you can write ethambutol, not a problem. It's one of the, again, drugs with moderate activity that can at least stop the proliferation and make the patient non-infectious as soon as possible. Okay, what about the sterilizing drugs? Okay, this is very, very important because they are the ones that are going to have a long-term benefit by killing these dormant bacteria. So first, very, very important drug is rifampicin. Rifampicin is going to be the most important drug, that is the most potent sterilizing agent. That's what I would tell, followed by pyrazinamide. So these two are the potent sterilizing agents. Then moderate potential is for INH, isoniazid, and poor activity is for ethambutol and streptomycin. Ethambutol and streptomycin has poor activity. So at least please do remember the drugs that have the highest activity against each and every topic. Like for example, isoniazid and rifampicin for preventing resistance, and isoniazid for early bactericidal activity, and your rifampicin, maybe a little bit of pyrazinamide for the sterilizing potential. But remember, rifampicin is the one that's going to have the highest sterilizing potential of all the drugs. And if they ask you the most potent ATT among all, you have to answer rifampicin. Definitely, no doubt about that. And if they ask you the most common drug in India against which Mycobacterium tuberculosis is resistant against, answer will be isoniazid, because 27% of the TB strains are actually resistant to isoniazid. But fortunately, many of the resistance are low-level strains, low-level resistant strains, which means they don't exhibit a high-level or high-grade resistance. So that is the reason why isoniazid still works for majority of the strains, at least maybe not fully, maybe partially it works, but still it works. So that's why we are able to give isoniazid now. But still, if they ask you the most common drug against which MTB is resistant against, then you have to answer straightforward, it is isoniazid. That's it. And similarly, if they ask you a drug with maximum or best CSF penetration, again, my answer is going to be isoniazid only. Isoniazid is the one that's going to be the best CNS penetration of all. Clear? The best CSF penetration. Clear? Similarly, pyrazinamide is also going to have a good CSF penetration. Even though I am not telling the best, it also has a reasonably good CSF penetration. But what are the drugs that are not going to have a good CNS penetration, or they're going to have a worse CNS penetration? Topmost on the worst is always streptomycin. It's a purely, water soluble agent, and it's very difficult to cross the blood-brain barrier. So that's why streptomycin, the worst CSF penetration of all. Other drugs, I'm not going to call it worst, but poor. Rifampicin, poor. Ethambutol, poor. These drugs are going to have poor CSF penetration. Even though not the worst like streptomycin, they're going to have a very poor CSF penetration. So the drugs with best CSF penetration, INH followed by pyrazinamide. The drugs with worst CSF penetration, streptomycin followed by rifampicin followed by ethambutol. These are the drugs that are going to have poor or worse CSF penetration. Now we have known the purpose of giving an anti-tubercular drug. This is the purpose which we have discussed already. Now, without wasting much time, let us move on to the properties of the first-line drugs. So we know the most important first-line drug is going to be isoniazid. This is the first drug which we're going to discuss. Simply you can write it as H. Yes. And next, we have to know the properties of this drug. We know it's a cidal drug. There is no doubt about that. And it's going to act on both intracellular as well as extracellular bacteria. Clear? And this isoniazid is especially effective for rapid multipliers. Isoniazid is especially effective for this group of bacteria called rapid multipliers, which are typically located on the wall of a cavity. This is the wall of a cavity, and in the wall of a cavity, there will be a lot of bacteria that will be rapidly and actively multiplying, and that is the one that is going to come into the cavity and get expectorated and makes the patient infectious. So that is why isoniazid, since of its, one of the best drugs that can act on the rapid multipliers, they kill this rapidly multiplying bacteria and prevent the movement of the bacteria into the cavity, which can be further expectorated, making the patient infectious. You can stop that. That is the reason why it's one of the best drug that has this early bactericidal activity, make the patient non-infectious. We have discussed already. It's one of the best drugs. That's the reason. And at the same time, metabolism of isoniazid. That's what we have to think about. This is a very important pharmacological aspect, metabolism, because metabolism of isoniazid is via acetylation. And there are two types of acetylators are there. One is the fast acetylators, second one is the slow acetylators. In Asia, typically the slow acetylators are the common ones. The abnormally slow acetylators actually metabolize isoniazid very, very slowly. So which means there is increased risk of INH toxicity. Toxicity means usually the most important toxicity with INH that we expect is the peripheral neuropathy. That's why these slow acetylators are going to have a high risk of getting peripheral neuropathy. At the same time, remember, this toxicity and peripheral neuropathy is generally due to pyridoxine deficiency, because INH acts as a direct antagonist of pyridoxine, which we'll discuss in some time. At the same time, these fast accelerators are common in European population, sometimes in white population, but in Asia and Southeast Asia, especially in Indian subcontinent, it's not that common. But here the problem is it will be metabolized too fast, so that you need excessive doses of INH. That's the idea. Clear? So let us see the mechanism of action of INH. So you have to understand a lot of stuff here, the mechanism of action. So what are the mechanism of action of isoniazid? First, you have to know a fact that isoniazid is a prodrug. INH is a prodrug which has to be converted to active form, And this conversion to active form is done by a protein called CatG gene product. CatG gene product in the Mycobacterium tuberculosis itself. So this CatG gene product means the CatG protein which is coded by the CatG gene. That's all. So once this active isoniazid is formed, it is going to inhibit a very, very important enzyme called ketoenol reductase. Ketoenol reductase. This ketoenol reductase forms a very important bacterial enzyme that is important for synthesizing a cell wall component called alpha mycolic acid. So which means this alpha mycolic acid is going to be integrated in the cell wall so that you get the cell wall production. Clear? So once you block the production of this ketoenol reductase, or if you reduce the activity of this ketoenol reductase, you're going to reduce the mycolic acid synthesis. That's alpha mycolic acid synthesis. That word alpha is important, which will mean in the subsequent minutes you will understand why that alpha word is important. And they're going to reduce the cell wall production, and that's how they kill the bacteria. And this ketoenol reductase is produced by a gene called INHA gene. That is the one that produces this enzyme called ketoenol reductase in the Mycobacterium tuberculosis. So the resistance can come from two areas. One is at the CatG level. So CatG level means they can have mutations of CatG. If you have mutations of this CatG gene, it's generally going to impart a very high grade resistance, point number one, because the INH, which is in the form of a prodrug, cannot be converted to active drug at all. So it's going to be a very high resistance to INH. And the moment you know it's a CatG resistance in your resistance testing, because we talked a lot about the drug sensitivity testing in the last video. The moment you know it's a high grade resistance, you have to omit INH. That's all. It's a CatG mutation means you have to omit INH from the regimen. There's no point in giving INH because it's not going to work anyways. It's only going to increase the side effects in this scenario. At the same time, you have to know a third point means there is no cross resistance to another similar drug called ethionamide. That's a very important point. No cross resistance to similar drugs. So that's a second line drug called ethionamide. Now, what about the problems with INHA? Remember, INHA doesn't get usually mutated, even though, like your textbooks, some textbooks do give mutated INHA, but I really don't believe it's mutated. But INHA tends to get overexpressed. So there will be something called overexpression of INHA gene, which means they are going to produce increased levels of ketoenol reductase. Once they start producing this increased levels of ketoenol reductase, even though INH is getting pro-INH is getting converted to active forms of INH, but still that will not be sufficient to inhibit all the enzymes where the bacteria is trying to produce in excessive amounts. So overexpression of INHA typically will not lead to very high grade resistance. It will result in low grade resistance only. But one good thing about this is you can still continue INH in these patients, continue isoniazid in these patients, but at a higher dose. The reason is very simple, because they are producing high amounts of the enzyme. We are using higher amounts of the drug so that they can neutralize. So that's the idea. So you can continue INH, and at high doses you can still give the INH. And the third point is the fact that there is some resistance to, or there is some cross resistance to ethionamide in this case. Cross resistance to ethionamide. Clear? So these are the two important mutations that you have to know, or two important things about the resistance of INH by the Mycobacterium tuberculosis. Remember, 27%, which means the most common drug against which MTB is resistant to is isoniazid only, in India at least. Then what are the side effects of this drug? INH. Let us see the side effects. I will write it here. So what are the side effects of this drug? Number one, always it's the peripheral neuropathy. That's going to be the most important side effect from INH. Again, I told you this peripheral neuropathy is due to pyridoxine deficiency, which this is because INH acts as a direct antagonist against pyridoxine. So which means you have to give prophylaxis with pyridoxine therapy. The brand name which you commonly use is called Benadryl. I'm not promoting any brand name, just to make you understand certain commonly used brands in India. That's why I'm telling the names. So this pyridoxine supplementation is almost given to all patients universally in India. But there are some indications that you have to know. These patients generally require pyridoxine replacement when you are using isoniazid. First one, HIV. Second one, malnutrition. Third one, children. And fourth one, alcoholic patients. Fifth one, diabetes. And last, uremia. Because uremia itself is a agent that causes significant peripheral neuropathy. If they ask you most common neurological complication in a CKD patient, it's peripheral neuropathy only. That is because of the uremia. Uremia is one of the very important toxins that causes peripheral neuropathy. You have to know about this. So with isoniazid and pyridoxine deficiency, this uremic patient, that is CKD patients, are at very, very high risk of developing peripheral neuropathy more compared to the normal population. That's why these patients need pyridoxine prophylaxis and supplementation. If you ask me, in India, almost all the patients who get tuberculosis will fall under this one of these categories. Especially in India, it's a common notion that whenever you get a tuberculosis, it is considered as a malnourished. He or she is considered as a malnourished patient. So almost all the patients do receive pyridoxine in the Indian subcontinent. Clear? So but on paper and theory-wise, these are the indications for pyridoxine supplementation when you are giving isoniazid. Second one, hepatotoxicity. Yes, this is very, very important. Isoniazid is one of the second most common drugs in the list for causing hepatotoxicity. Hepatotoxicity with ATTs is one of a very, very important topic you should understand. If they ask you the most hepatotoxic drug, it's always pyrazinamide only. This will be followed by your isoniazid. This will be followed by rifampicin. So this is considered to be the order, even though some textbooks will give a different order with respect to isoniazid and rifampicin, but I believe this is the order, and pyrazinamide always is the most hepatotoxic drug among the first line drugs. At the same time, it is the most common drug to result in altered liver enzymes. Most common drug to result in altered liver enzymes after starting antitubercular therapy. And this is the most common drug to cause hepatotoxicity in a patient who is on antitubercular therapy. Clear? All these facts are very, very important, because next time whenever a patient comes with hepatotoxicity, I'm not telling it's exclusive to pyrazinamide, but I will think about pyrazinamide only as a culprit. That's a usual case. Number 3, there are some other side effects of pyrazinamide, like it can cause optic neuritis. Definitely yes. Don't think only about ethambutol. Ethambutol is the most common reason for optic neuritis in a patient who is on antitubercular therapy, but do remember about this isoniazid also after ethambutol. then you can get with certain disorders like drug-induced lupus erythematosus, where one of the drugs that causes drug-induced lupus erythematosus is isoniazid, which we'll discuss in rheumatology section extensively. And they can cause hypersensitivity reactions, but generally very rare. Hypersensitivity usually will be due to rifampicin. We'll see in the next drug, that is rifampicin. Then finally, they can produce a bit of gynecomastia, but all these are generally very, very rare. Whenever I tell others means it's generally very rare. We don't really encounter that much. Clear? So these are the important side effects of isoniazid that you should know. Second, let us move on to the another drug, most potent ATT, most potent antitubercular drug, quintessential component of any antitubercular regime, that is rifampicin. Okay, I've given a lot of build-up for this drug, rifampicin. So, what are the properties of rifampicin? What you are going to see in the rifampicin? So, obviously, it's a cidal drug, and remember, it is the most potent ATT. At the same time, this is the drug that's going to act on the dormant bacilli. That is, it penetrates the caseous necrosis, and its action is predominantly on the dormant bacilli. Clear? The same diagram will take. Here, I told you, where is that? Yeah. So, how isoniazid works on the wall of the cavity against the rapid multipliers and prevent the expectoration of this bacteria and making the patient non-infectious. Rifampicin is one agent that is going to act in the caseous necrosis. In the same area, there will be caseous necrosis in a lot of areas. They're going to act on the caseous necrosis. In this diagram, if you take this dormant bacilli, already we discussed this caseous necrosis is very important. That is where your dormant and semi-dormant bacilli will be. The rifampicin is going to act right in that area. Okay, we'll go back to that. So, which means it's the one that's going to penetrate into the caseous necrosis and going to act on the dormant and semi-dormant bacilli inside the caseous necrosis. Clear? And one of the important other aspect of rifampicin is the fact that it's going to act on both intracellular as well as extracellular bacteria, like your isoniazid. I told you only two drugs that act purely on intracellular or extracellular, like pyrazinamide acts only on intracellular bacteria, and streptomycin acts only on extracellular bacteria. But this drug, isoniazid and ethambutol, is going to act both on intracellular as well as extracellular bacteria. Fine. Now, there are a lot of other uses of rifampicin apart from your antitubercular therapy, which means you know that rifampicin will be used in leprosy, one of the important part of your anti-leprosy regime, and it's also used for meningococcal prophylaxis, which means who will be getting this prophylaxis are the persons who have been exposed to meningococcal meningitis patients or contacts of meningococcal meningitis patients. You have to give some prophylaxis. Usually, rifampicin is one drug that is preferred and that was preferred, but right now, currently we don't use that rifampicin as a standard treatment for this purpose, because the dose of rifampicin itself is a limiting one. We have to give 600 milligram 2 times a day, and you have to give for 2 days. So this is where the problem with rifampicin is. You need 2 doses and for 2 days. So the compliance factor is an issue here. Patient might not take or forget to take this. That's why there are newer alternatives, like you can give ceftriaxone, just a 250 milligram intramuscular, but a stat dose. It means a point of care dose, but still it is intramuscular. So some patients may not be willing for that. That's why we have newer alternatives like ciprofloxacin, where just you give a 500 milligram oral dose, but a stat dose, or you can even use an azithromycin 500 milligram oral stat dose. But currently what we are going to prefer is the ciprofloxacin 500 milligram, just a single dose, because of the cost, which is very less for ciprofloxacin. At the same time, efficacy is almost equal to other regimens which you have discussed. At the same time, the tolerance to the dose is very high and the side effects is comparatively less compared to other drugs. At the same time, it's an oral drug. So a lot of reasons are there why we are going to use ciprofloxacin. Clear? And the compliance is also very high because it's an oral drug and a single dose. So this is the reason why currently we prefer ciprofloxacin for this purpose. We don't prefer rifampicin any longer. But still, you have to know that point. Rifampicin is also used for prophylaxis of meningococcal meningitis. Then third one, they can be used in prosthetic valve infections also, because whenever you have a prosthetic valve infection, there will be a slime layer that will be formed. Clear? So it's very difficult to break this layer because, I mean, this is a foreign body, like it's like a foreign agent. This is a metallic prosthetic valve or something. So it's very difficult to break this layer, and it's very difficult to enter into the, because the bacteria will be proliferating at this zone. Clear? The bacteria will be proliferating here, and these biofilms typically protect this bacteria, and the antibiotics will not enter into this biofilms. That's why they produce this biofilm. So rifampicin is one agent that typically breaks this biofilms. They break the biofilm and make the antibiotics penetrate into the biofilm, and they will destroy the bacteria. So that's why in a prosthetic valve infection, this rifampicin can be used as a adjunct, especially if it's a metallic prosthetic valve. Definitely this is a very important adjunctive therapy. So you have to know that. So these are some of the other use of rifampicin. We have a lot of other uses also. And apart from that, rifampicin has to be taken in empty stomach. That's a well-known fact. Why? Because rifampicin's absorption is decreased by food. So food reduces the absorption of rifampicin. So that is the reason why it has to be taken in the empty stomach. And next important property of rifampicin is its enzyme inducing potential. Very, very, very important. It's a significant enzyme inducer, cytochrome enzyme inducer, which means it's typically metabolized in the liver only and is eliminated in the feces more than the urine. Even though some of the metabolites are eliminated in the urine also, but predominantly it's eliminated in the feces only. Clear? Its metabolism is through the liver, obviously. So since it's metabolized in the liver, they can activate a lot of enzymes in the liver, especially the cytochrome enzymes, which means it can make a lot of drugs get metabolized faster, which means they can reduce the level of those drugs in the blood very rapidly. Which means this is one drug, rifampicin, that is important for poor efficacy of many drugs. Poor efficacy of other drugs because of rapid metabolism and reduced levels in the blood. For example, HIV related drugs. Whenever HIV patient is getting tuberculosis, we really are afraid to add rifampicin. Instead, that's why they will tell to add rifabutin, because rifampicin will accelerate the metabolism of this anti-HIV drugs, and they might result in poor efficacy of this anti-HIV drugs, which means HIV might become a problem again if you add rifampicin. So that is why we don't give rifampicin to these patients, and like that you can have many other problems because of this enzyme inducing activity of rifampicin. Clear? So it's a very important thing. At the same time, I told you one more point. It's predominantly through the liver and majority, almost entirely through the feces and very little through the urine. This makes this rifampicin the most safest ATT in renal failure. Clear? This makes rifampicin the most safest anti-tubercular therapy, anti-tubercular drug in renal failure patients. For liver failure, the most safest will be your streptomycin. That's the most safest in liver failure patients. But in renal failure patients, the most safest is going to be the rifampicin only. We have discussed a lot of things, but we have not yet discussed about the mechanism of action. Mechanism of action of rifampicin is simple. It's an inhibitor of DNA transcription, which means it prevents the formation of mRNA by inhibiting an enzyme called DNA-dependent RNA polymerase. Clear? DNA-dependent RNA polymerase. And this has multiple subunits, but one of the subunits is beta subunit. Why I'm telling this beta subunit? Because it's coded by a gene called RPOB gene. And why should I tell about RPOB gene? Because rifampicin binds to RPOB gene in the beta subunit of the DNA-dependent RNA polymerase. That's how it inhibits the action of this enzyme. That's why it reduces the activity of this enzyme. And that's also the same reason why these patients can go for mutations in this RPOB gene, which means this is the reason why you get rifampicin resistance. Clear? Mutations in the RPOB gene, because this RPOB gene mutations will make the protein, different mutated protein that may not bind with rifampicin, so that your rifampicin action may no longer be exerted. So this is one of the reasons why you get resistance with rifampicin, mutation in the RPOB gene. Very, very important to understand. Clear? I'll tell you, I'll compile all the data at the end, but right now understand this RPO gene mutation is important for rifampicin resistance. And now let us move on to the side effects. What are the side effects of this drug? Again, very important. Clear? Side effects of this drug, the most important and easiest to know, and everyone knows that, is the fact that it causes orangish discoloration of the urine. Orangish discoloration of the urine. That is because certain metabolites of rifampicin are still eliminated in urine, and they can produce orangish discoloration of the urine because they are naturally orange color. That's why. It is very important to inform this to the patient. It's a very benign condition. It's not harmful. It's an entirely harmless state. But still, it's very important to explain this to the patient because sometimes they might confuse this orange discoloration for hematuria, and they might think that the drug you have given is causing side effects, especially from people who are not having sufficient knowledge about these drugs. They might be thinking doctor has given too much of a dose and it's causing some problem inside me. My kidney is gone, and they will stop the drug. This is still a thought in our Indian patients at least. So tell this to the patients. It will cause orangish discoloration of the urine for sure. And it's nothing to be worried, and it's a natural effect of the drug. And number 2, there is still a risk of hepatotoxicity, and that is dose dependent. It's not a safe ATT in liver failure. It still causes some risk of hepatotoxicity still there, but not like pyrazinamide, but still risk is there. And it is typically dose dependent side effect. Number 3, you can also get certain immunoallergic complications. And this is very, very important because this is dose independent side effect. At the same time, it can cause a lot of reactions ranging from a minor reaction to a major reaction. Minor reaction usually will be cutaneous rash, itching. This is very, very common. Actually, whenever a patient after starting a antitubercular therapy comes with rash, itching, typical like allergy-like reaction, I will always think about rifampicin as the first possibility. Similarly, whenever a patient comes with hepatotoxicity, elevated liver enzymes, I will first think about pyrazinamide as the possibility. These are 2 entities in practice, you have to know about it. But anyway, let us move on. So they can also produce a flu-like syndrome. It's also due to immunologic manifestation, or they can produce gastrointestinal intolerance also. All these are immunologic manifestations. Or it can produce even a major event like intravascular hemolytic anemia. Because of that, they can go for renal failure because of hemoglobinuria, and they can produce shock and even death. Clear potential death is also there. And this renal failure can be either due to hemoglobinuria, or they may due to acute interstitial nephritis also. That also can be a reason for why you get a renal failure. Both hemoglobinuria as well as acute interstitial nephritis, because it's allergy kind of a nephritis. That's why acute interstitial nephritis due to drugs means it's allergy only. Where you will see eosinophiluria, eosinophilia in the blood, all these things we'll discuss in the kidney section in detail. But right now, just remember they can produce renal failure due to this immunologic manifestations. At the same time, I believe this is the most important, maybe a bit of a postgraduate point, but still very easy to understand. That's called a pseudo-adrenal crisis. What do you mean by pseudo-adrenal crisis? It's not typically Addison. I told you an important property of rifampicin is there, that is enzyme induction. That's what is going to be useful here, because cortisol will be metabolized by cytochrome enzymes only, certain cytochrome enzymes. So remember, because of the enzyme inducing potential of rifampicin, because rifampicin is going to accelerate a lot of enzymes, and that is going to accelerate the metabolism of cortisol, and they are going to relatively reduce the cortisol production. Suppose if it's a normal adrenal gland, I won't have an issue, because this normal adrenal gland definitely will try to increase the synthesis of cortisol. Because of that, this excessive metabolism will be like counteracting with the increased synthesis so that you will have a normal cortisol. So normal adrenal gland will be able to do that. So not an issue. But in TB patients, especially I told you TB patients, many of the patients may have dissemination to adrenal glands. We might not be knowing. It might be a small dissemination where the patients might be having occult adrenal insufficiency. These patients, they cannot increase the cortisol synthesis. They will be just managing with some cortisol that is getting synthesized. Even though they don't go for overt adrenal failure, they will have occult adrenal insufficiency on the background. That will be just okay for them. But the moment you give rifampicin to these patients who are having already occult adrenal insufficiency, they can no longer increase the cortisol. They cannot increase the synthesis any further. Cannot increase cortisol synthesis any further, which means the moment you give rifampicin, metabolism of cortisol will increase and the cortisol levels will drop immediately, resulting in these patients are the ones that are going to be prone for this adrenal insufficiency, which means giving rifampicin does not cause adrenal insufficiency. It brings the overt adrenal insufficiency into, brings the background occult adrenal insufficiency into overt adrenal insufficiency. That's all. Clear? That is why it's called a pseudo adrenal crisis. It's not a rifampicin induced adrenal damage or true adrenal crisis. It's because rifampicin brings out this occult adrenal insufficiency picture into a a very well-defined adrenal insufficiency, which means patient might be having simple fatigue, but electrolytes may be borderline or normal. But giving rifampicin immediately will push patient to hypotension or shock, and it might result in hyperkalemia, hyponatremia, and salt wasting in the urine, and overt adrenal insufficiency like picture. So you have to be very careful about this. Clear? Whenever I give rifampicin, the patient goes for adrenal insufficiency, I will surely, it's an indirect evidence that the patient is having adrenal tuberculosis also. But it's not at the level of producing overt, but rifampicin is bringing them to the surface. That's all. So these are some of the important and interesting side effects of rifampicin, and we have discussed in detail about what is rifampicin, and we will move on to the next drug, that is pyrazinamide. Pyrazinamide. You know, pyrazinamide is also a cidal drug. We know that. And it is one drug that is going to typically act on the intracellular bacteria. It's one drug that's going to typically act on the intracellular bacteria, which means they are going to act on this slow multipliers. Slow multipliers. Remember, rapid multipliers, INH, caseous necrosis, dormant bacilli rifampicin, it's for slow multipliers. Clear? At the same time, the metabolism is typically through the liver, and that is the reason why it is hepatotoxic. Metabolism is typically through the liver and it can produce serious hepatotoxicity. At the same time, remember the fact that even though they are metabolized in the liver, the metabolites are actually excreted through the kidney. Kidneys are the ones that excrete these metabolites that are produced by the liver. So this understanding is again very, very important. And next, what is the mechanism of action of pyrazinamide? What is the mechanism of action? Mechanism of action is complicated, and many of the studies are telling we really don't know what is the mechanism, but still we can try to understand the mechanism. What is important to understand that this pyrazinamide, after it enters the cell of a Mycobacterium tuberculosis, which means it's going into the Mycobacterium tuberculosis cell, where it will be converted to another compound. It's an active compound called pyrazinoic acid. So remember, this pyrazinamide is a prodrug by nature, and it will be converted to active component that's called pyrazinoic acid, which is the one that's going to exert effects inside the MTB cell, and this is done by a protein called PNCA gene product, which means this PNCA is a protein that is coming from a PNCA gene. So you can remember both together, PNCA gene giving rise to PNCA protein, that is gene product. So that is the one that's going to convert this pyrazinamide prodrug to pyrazinoic acid active form. And this is going to exert certain effects. Number one, the first one is to reduce the translation, that is formation of proteins, protein synthesis inside the bacteria. And that is by inhibiting one of the important proteins called ribosomal protein S1. Ribosomal protein S1. Number two, it inhibits fatty acid synthesis by inhibiting an enzyme called fatty acid synthase 1. Number 2. Similarly, number 3, it also disrupts the mycobacterial membrane potentials. Through a lot of mechanisms are there, mycobacterial membrane potentials, and all these 3 metabolisms have been described, which happens concurrently after giving pyrazinamide. But the most important is supposed to be this, according to a lot of studies and researchers, this reduced translation protein synthesis by inhibiting ribosomal protein S1 in the bacteria is the most important. It's supposed to be the most important according to the researchers. Clear? So this is how your pyrazinamide acts. And the mechanism of resistance is the same. For example, if you have a mutation in this PNCA gene, in which you are not going to convert this pyrazinamide into active pyrazinoic acid, so there will be a very high grade resistance to this drug. So that's how the bacteria develops resistance. And let us move on to the side effects, which are really, really important for pyrazinamide as well. And if they ask you the most common side effect, I'll be answering arthralgia. That's the most common. It's been thought that it produces an astonishing 10 to 30% of the cases develop arthralgia due to pyrazinamide. And most important is because the pyrazinamide also produces hyperuricemia. You might be thinking, you might be relating this arthralgia to this hyperuricemia. Actually, no. It's not because of the hyperuricemia that you commonly get arthralgia, which means this arthralgia most common form is non-gouty arthritis, which means it's not due to gout. But hyperuricemia can itself cause gout. That is different. That is gouty arthritis. But that's not the common cause. That's not the common side effect. That is arthralgia. Arthralgia is not due to gouty. I mean, most commonly, this arthralgia is not due to the gout and hyperuricemia. Hyperuricemia, even though they can cause gout, but typically the arthralgia due to pyrazinamide is non-gouty in nature. So I hope I am not confusing. So this is what is very important to understand. Next, at the same time, the reason for hyperuricemia is because of the activation of the URAT transporters, especially the URAT1 transporters, which means they increase the reabsorption of uric acid. Increase reabsorption of uric acid, which means it's a poor excretion. Because whenever you talk about hyperuricemia, which we'll discuss in rheumatology, there are 2 types of hyperuricemic patients. One is called overproducers and second is underexcretors. Pyrazinamide will result in underexcretion of uric acid. Clear? By increasing the reabsorption of this uric acid through URAT1. Clear? So these are the ideas. Okay. Then next one is heterotoxicity, obviously. Remember, pyrazinamide is one of the most hepatotoxic drug. If I'm not wrong, it is the most hepatotoxic drug. And I told you already, the most common ATD that will be responsible for this hepatotoxicity and elevate liver enzymes in a patient who is receiving antitubercular therapy is pyrazinamide. And it can also result in porphyria or it can precipitate a porphyric attack. So this is also very important to understand. Clear? So these are the 4 side effects. I told you arthralgia, usually non-gouty, hyperuricemia may result in gouty, but not common, and hepatotoxicity as well as porphyria. The 2 most important things, if you want to know, that is arthralgia and hepatotoxicity. These are 2 things that you should never forget in the exam. Clear? And the next first line ATT that we're going to discuss is on ethambutol. You can write as E here. Fine. So remember, this is a static drug. We know that this is the only static drug among the first line ATTs, and it's going to act both on intracellular as well as extracellular bacteria like isoniazid and rifampicin. At the same time, it is one drug that's also going to act on the rapid multipliers or rapid growers that is present on the cavity wall typically, like isoniazid, but even though not as effective as isoniazid, but still it's going to act on rapid multipliers like isoniazid. And mechanism of action of ethambutol is very simple. It's going to inhibit an enzyme called arabinosyl transferase, which is coded by a gene called EMBP gene in the mycobacteria. This arabinosyl transferase is very important for synthesizing a molecule called arabinogalactan. And this has to combine with mycolic acid to produce a good cell wall. Clear? So because your arabinosyl transferase enzyme is inhibited by ethambutol, your arabinogalactan synthesis will drop, which means the mycolic acid cannot mix with the arabinogalactan, so that your cell wall synthesis will drop. Because majority of the ATTs, they are going to act through the cell wall synthesis pathway only. So this is no different anyway. So it's going to reduce the arabinogalactan synthesis by inhibiting arabinosyl transferase enzyme. So the mutations will usually happen in the EMBB gene, and this EMBB gene mutations are the ones that are going to be resistant strains, which means these are the ones that are going to result in resistance to ethambutol. Clear? The mutation in the EMBB gene, that's what I remember. So we have seen CAT gene INHA for our isoniazid, then RPOB gene for rifampicin, then PNCA for pyrazinamide, and now we are seeing EMBB gene for this ethambutol. Clear? So this is very important to understand. Fine. And you know what will be the side effect of this ethambutol? It's actually quite safe drug. The only important side effect and significant side effect will be optic neuritis. If they tell you optic neuritis, most common reason in a patient who's on ATD, antitubercular drug, it is ethambutol. Even though isoniazid can cause optic neuritis to an extent, but ethambutol is always the norm for exams at least. Number 5, streptomycin. Streptomycin is, it's an aminoglycoside, which means it's going to reduce the protein synthesis, obviously, by inhibiting ribosomal subunits. So protein synthesis decrease is the most important action of any aminoglycoside. So they are protein synthesis inhibitors, streptomycin. Remember, this is a cidal drug, obviously, there is no doubt about that, and it's going to predominantly or typically act only on the extracellular bacteria. Clear? At the same time, this streptomycin is also going to act on the rapidly multiplying bacteria, even though it is not as effective, but to an extent it's effective for this rapid multiplies or rapid growing bacteria. So these are the 3 properties that you have to know. At the same time, you have to be absolutely sure that no aminoglycoside has oral absorption. No oral absorption, it has to be given parenterally. Typically, streptomycin in TB we give as an IM dose. Clear? The dose is different. Typically, we follow the daily doses as per I told you in the previous video itself, where currently we are moving towards daily dosage regimens. So typical Indian dose, what we follow is 750 milligram IM daily dose. That's what the streptomycin dose we follow. But it all depends again. Let us see after some time in the treatment algorithm in the next video. So no oral, typically used as a IM regimen. Remember, all the other first line drugs we have discussed here are oral drugs. They are not available parenterally. But this streptomycin can be given only parenterally, and it cannot be used orally. In fact, none of the aminoglycosides can be given orally. There are a lot of properties of aminoglycosides, which may be in an ID bonus section we'll be discussing maybe after the completion of all these videos. We'll be discussing later on, after May or June. But right now, let us discuss on the streptomycin part. Okay, what are the side effects? You know very well the side effects of streptomycin and aminoglycosides. They are going to cause ototoxicity. They can cause vestibulotoxicity, or we can write as otovestibulotoxicity, or they can cause nephrotoxicity. At the same time, they can also produce hypokalemia and hypomagnesemia. Both are features. So all these are general toxicities of aminoglycosides, not only streptomycin. So these are going to be the same side effects for these drugs as well. Now we can move on to the second line antitubercular drugs, second line antitubercular therapy. In this, we have certain cidal agents and we have certain static agents. And we are only talking about drugs that have proven efficacy as an antitubercular agent. We are not going to talk about drugs that have unproven efficacy or not. So what are the drugs that have proven efficacy for Mycobacterium tuberculosis? Second line drugs. Cidal drugs, the newer drugs are definitely cidal. Like you have this bedaquiline, the most important drug as of now and one of the most hyped drugs. Yes, it does live up to the hype, especially for MDR tuberculosis bacteria. And who knows, this drug might even be fast-tracked into a first-line ATT in the future if the resistance rates are increasing. But keep a track on bedaquiline, very important drug for exam. Then you have 2 other new drugs called delamanid and pritomanid, but please note that pritomanid is not even available in India right now. Okay, these both are going to have the same mechanism of action, and bedaquiline is going to have a little bit different action. Then you have cycloserine, you have clofazimine, and we have forgot the most important fluoroquinolones, and we even forgot a second line injectable drugs. These are again the aminoglycosides acid that we are going to use, the kanamycin and capromycin. So these are some of the second line drugs that you have to know, sidal drugs. And static drugs, I told you these are the PET group of drugs. We know PAS, ethionamide, and thioestazone. Clear? So these are the PET group of drugs. PETs are static, I told you already. So these are the bacteriostatic second line agents. But there are certain other agents with unproven efficacy, other second line drugs, but these have unproven efficacy, which means they should not be typically considered as an antitubercular drug, but they have unproven, and some small researchers have shown some efficacy in vitro, but we don't know what will happen inside the body in vivo. So what are those drugs? Like certain beta lactams like amoxicillin clavulanic acid combination. Then other beta lactams like meropenem has shown some activity in vitro, and we have certain macrolide drugs, especially clarithromycin and azithromycin, and other drugs like linezolid. Clear? So these are some of the drugs that have shown a reasonable efficacy in Mycobacterium tuberculosis also, but in vitro, but in vivo efficacy has not been clearly proven. Understood? So these are the important second line drugs that you have to know. So let us discuss on the ever important bedaquiline first. That's why I wanted to put it on the top, because this is going to be the most important drug for your exam. Bedaquiline, for that matters, first you have to know it's a sidal drug, and it has excellent property of acting on rapid multipliers as well as on the dormant bacteria, which means these drugs are going to have excellent sterilizing activity as well. They act on the dormant bacilli also, and this action of bedaquiline becomes synergistic with pyrazinamide. You have to know that point. Action is synergistic with pyrazinamide. Very, very important point. And it's a sidal drug for sure. And it has excellent sterilizing potential also, which means it's going to act in the casus necrosis, and it's going to act on the dormant bacilli as well. And mechanism of action of bedaquiline is going to be inhibition of mycobacterial ATP synthase, not our human ATP synthase, mycobacterial ATP synthase. And side effects, very little but very important. Nausea, vomiting, arthralgias tend to be the common side effects, but a very dangerous side effect called prolonged QT interval. And this is being especially very important for elderly patients and those who are receiving multiple drugs, because they can have synergistic effect with drugs causing QT prolongation also. And this is very, very important in patients who are receiving moxifloxacin or levofloxacin. Moxifloxacin and levofloxacin, and this is also significant in patients who are receiving clofazimine, because you can understand this fact because moxifloxacin and levofloxacin and clofazimine are also second line ADTs, which means a patient who's taking bedaquiline may be on moxifloxacin, it's a fluoroquinolone, and clofazimine, both of which are going to elevate the QT interval. So giving along with these drugs, you have to be very, very careful, because they can prolong the QT interval to great extent, and they can predispose to ventricular tachyarrhythmias like Torsades and even death. So you have to be very, very careful in these drug interactions. At the same time, you have to avoid this drug. You have to avoid this drug in patients who are having history of ventricular arrhythmias, and in patients who are having a corrected QT interval of more than 450 milliseconds. Clear? Because normal QT interval is somewhere around 0.35 to 0.45 seconds or 350 to 450 milliseconds, you can tell in any way. But if it's more than 450 milliseconds or more than 0.45 seconds, both are equal in terms of math. So in these conditions, you have to avoid bedaquiline. And remember, bedaquiline is not advocated in pregnant women, avoid in pregnant women, not yet advocated, and in children as well, not studied in children. And concurrent use of these fluoroquinolones and clofazimine also should be avoided when the patient is on bedaquiline. Clear? Currently, it's one of the standard drugs for MDR and XDR TB. For MDR TB is the one that is currently preferred because of the high cost of this drug. Later on, once the cost reduces, it might be fast-tracked into different reasons into first line ADTs also, but that's a long shot. But right now it's approved for MDR-TB by different guidelines around the world as well as in India, Indian RNTCP guidelines. The dose is approximately 400 milligram once daily for 2 weeks, followed by 200 milligram 3 times per week for almost 24 months. So this is the dose for MDR-TB. Clear? 200 milligram 3 times per week for thrice weekly for almost 24 months. So this is the standard dose of bedaquiline. Clear? Bedaquiline resistance means resistance is uncommon, but bedaquiline resistance means there is some cross resistance to other ATTs, especially clofazimine. Some other ATTs are also possible, but cross resistance to clofazimine is there once the tuberculous bacteria gets bedaquiline resistance. But again, that's not currently a problem, but so that we're not going to discuss much about it. Then we have to discuss about other two important drugs. This is delaminid and pretominid, which belong to the same class. That's called mycolic acid synthesis inhibitors. These are mycolic acid synthesis inhibitors, which means they are going to reduce the production of the cell wall. Clear? Yes. So what mycolic acid they are going to reduce the synthesis? It's going to reduce the methoxy mycolic acid, mycolic acid, and next is the ketomycolic acid. Ketomycolic acid. These are the two mycolic acid synthesis that this delaminid and pretominid is going to inhibit. But this is the point I told you before. When you take the isoniazid, I told you in the beginning itself, they are going to inhibit typically, where is that? This alpha mycolic acid. Clear? That is why I've told you there itself it's an important point, because this delaminid and pretominid are going to inhibit the methoxymycolic acid and ketomycolic acid synthesis, not the alpha mycolic acid synthesis. Clear? That's why that point is important. So again, they are cidal drugs. There's no doubt about that. They are cidal drugs. And very important point, major difference from bedaquiline is the fact that they can be used in children, even though they cannot be used in pregnant women as of now. But children, yes, you can use this in children, especially in the age group of 16 to 17 years. You can use less than 6 years. Again, trials are ongoing. We don't know the safety and efficacy. But 6 to 17 years, children, surely you can use. 18 plus, definitely they become an adult, so you can use for sure. But children 6 to 17, it's approved. But bedaquiline is not yet approved for use in children. And what are the side effects of these drugs? Side effects again is going to be increased QT prolongation, even though pretominid has a little bit of a reduced risk for this QT prolongation as this is concerned. But delaminid definitely has a significant rise in QT prolongation. That's the reason why you should avoid this drug. Like same what you told for your bedaquiline, this should be avoided in patients who are having history of ventricular tachyarrhythmias. And patients who are having a corrected QTC interval of more than 450 milliseconds, and patients who are concurrently taking fluoroquinolones, moxifloxacin and levofloxacin or clofazimine, because these drugs are also going to elevate the QT interval, and the action may become, side effect itself may become synergistic, and the patient may die of TOSET. So avoid concurrently using a fluoroquinolone and a clofazimine. Clear? Currently approved for MDR and XDR-TB like bedaquiline, and the dose is going to be 100 milligram 2 times a day for 6 months. And very important point with delaminid and pretominid is there is no cross resistance to other ATTs. Absolutely no cross resistance to any other ATTs. Bedaquiline does. So these are some of the differences between bedaquiline and the other two newer drugs, that is delaminid and pretominid. And we can see some important properties of the fluoroquinolones also, because fluoroquinolones are quintessential second-line drugs, shows very good activity against Mycobacterium tuberculosis. So that is also one reason why a patient comes with LRE symptoms, you initially don't start with fluoroquinolones, because your sputum tests when you take for AFB can become negative, and the gene expert also can become negative, because your bacterial load might decrease, because these are excellent cidal drugs. And again, very good drugs, very good second-line drugs. Compared to all the other drugs, this has little less side effects. At the same time, they are excellent drugs. and one of the very effective ATTs, I told you. Mechanism action, they are going to inhibit the DNA gyrase enzyme, and this is coded by your gyrase gene. Obviously, resistance to fluoroquinolones will be due to mutations in the gyrase gene. We know that fact. Then, what drug we are going to currently use is only two, that is levofloxacin and moxifloxacin. Very commonly used is levofloxacin, but gatifloxacin is never available for systemic use, even though they are having in vitro activity against tuberculosis in a very good way. And ofloxacin is never used nowadays. Majority of the tuberculous bacteria are resistant to ofloxacin. So we currently use levofloxacin very commonly, or we can use moxifloxacin. Levofloxacin is very commonly used drug. Even some pulmonologists add as a first line drug itself, and they have their own guidelines. It's not universal. Your RNTSB never advocates use of levofloxacin as a first line drug, but I'm telling you because of the importance of this levofloxacin, how effective this drug is. Very, very effective for Mycobacterium tuberculosis. And they can also cause QT prolongation. So let us see the side effects. They can also cause QT prolongation. It's a very, very well-known drug to cause QT prolongation. We'll discuss in cardiology because there are some drug-induced QT prolongation. I have discussed extensively in cardiology in the future. So prolonged QTC. And that is also the one reason why we should not use this drug along with our bedaquiline and predominant and delaminate. Why? Because they also cause QT prolongation, these also cause QT prolongation, and they can produce synergistic effects. So that's why. And these drugs can produce photosensitivity, and these drugs can produce peripheral neuropathy given for a long time, and a lot of other side effects. And fluoroquinolones can cause tendinitis and Achilles tendon rupture, and it is not approved for use in pregnant women at the same time. It cannot be used in children less than 8 years of age also because of the risk of tendinitis in the fetus, and if you're using in a child because of tendinitis and Achilles tendon rupture risk in a child. So that's why we don't use, but they can cause other side effects like this also, but the most decorated side effect is going to be the prolonged QT interval. Very important side effect. Clear? So now let us see some of the few details on second line injectable agents. Second line injectable agents, I told you they are cidal, all right. They are aminoglycosides, which means typically they will be acting on the extracellular bacteria only. But more importantly, they are having very poor sterilizing action. Poor sterilizing action. Like like your streptomycin, because aminoglycosides generally do not have a good sterilizing action. They have a very poor sterilizing action, which means they are not going to work on the dormant bacilli and caseous necrosis. They are going to only work on the extracellular growing bacteria. That's all. The true drugs that we use, I told you, are kanamycin and capreomycin. Remember, the resistance patterns are also different. So what are the reasons for resistance? Depending on different genes. So universal resistance to all aminoglycosides will be there, including streptomycin, kanamycin, capreomycin, because of mutations in a gene called RRS gene. RRS gene mutation will render the particular bacterial strain resistant to almost all the aminoglycosides. But selective aminoglycosides, like for example, selective aminoglycosides, you can develop resistance with TLYA, which renders this bacteria resistant to capreomycin, TLYA gene mutations. And next we have EAS gene mutations, which renders the bacteria resistant to kanamycin. Clear? So all these three gene mutations are very important for your understanding for exams. Clear? So whenever there is kanamycin resistance, suppose kanamycin resistance is there, it also means amikacin resistance. Kanamycin resistance means it's amikacin resistance. But whenever there's a kanamycin resistance, it's only equivalent to amikacin resistance, which means your capreomycin will still be effective for treating these patients. So that's very important point again. Kanamycin resistance means amikacin resistance. In this condition only, still your capreomycin may be sensitive. So you can use capreomycin for this. Patients are having only isolated kanamycin or amikacin resistance. Clear? So these are some important points that you have to know. Then let us discuss about cycloserine. So we can discuss separately because there is already messy over there. So let us discuss on cycloserine. Cycloserine, they are going to reduce the cell wall synthesis again. How? Because this drug is an analog of D-alanine. This drug is an analog of D-alanine, which is very important building block of the cell wall. And this is very important for understanding because you can see this in your mechanism of beta-lactam drugs itself, penicillin action itself, this D-alanine will come there. So you can understand this D-alanine is a very important building block of the cell wall. So that's how they reduce the cell wall synthesis. And this is a sidal drug, all right, that's what we're discussing here. At the same time, the side effects are what is very important. What are the side effects? Very typically, they're going to cause neuropsychiatric complications, which means this should be avoided in a patient who's having a pre-existing psychiatric disorder, suicidal tendency, depression, psychosis. It's better to avoid this drug because they themselves can induce suicidal tendencies and a lot of neuropsychiatric issues. And please start this drug only after getting a psychiatrist opinion. In India, that is very important. Don't start this drug without a psychiatrist opinion, at least for documentation purpose, because of this very important side effect and can be very serious and severe also. Then we have another drug called clofazimine. Clofazimine, how clofazimine is going to work? It's going to bind with the DNA bases, guanine bases in the DNA, binds to the guanine bases in the DNA, and by binding to the guanine bases in the DNA, they can reduce the DNA replication. They can reduce the DNA replication, which means the template function of the DNA will be lost. So that is the main mechanism of how this clofazimine is going to work. It's a very important anti-leprosy drug also. We'll see there as well. And it's going to be a good sidal drug. At the same time, what are the important side effects of this drug? Very common. That's what they'll be asking in exam. That is pink to brown skin discoloration. Pink to brown skin discoloration. And this is the most common, that's skin pigmentation. This is the most common side effect happening in almost 75 to 100% of the patients who's taking clofazimine at least for 1 month or more. Definitive side effects, 75 to 100%, most common side effect, discoloration, skin pigmentation, very, very important. And even their sweat might be having this kind of color. So they can, I mean, even the cloths might stain, especially if you are wearing white color cloths, it might stain your white color cloths with this pink to brown secretions. So very annoying side effect to an extent for some patients, and it can cause photosensitivity and it can cause a lot of troublesome gastrointestinal complications also. But obviously in exam, this will be the most important question, side effect related question, clear? So I think we have seen clofazimine, we have seen cycloserine, and we have completed almost all the sidal drugs, and we have only the static drugs left. There are 3 static drugs we know that is pars, ethionamide and thiazolone. Let us see some of the effects of pars. That's called para-amino salicylic acid. That's it. Expansion of the acronym for pars, but the real name is 4-amino salicylic acid. 4-amino salicylic acid. And mechanism of action is similar to that of trimethoprim sulfamethoxazole. That's cotrimoxazole, which means they are going to inhibit DHFR, dihydrofolate reductase, which means they are going to reduce the active folate synthesis, inhibit the folate pathway. So it's a folate pathway issue. Side effects also will be similar to that only. And you know this is static drug, I need not write again. And the side effects are going to be gastrointestinal side effects. And this can be really troublesome to some patients like nausea, vomiting and diarrhea. And this is also one drug that produces heterotoxicity. Clear? This is also one drug that's going to produce heterotoxicity. So very important. And they can also produce megaloblastic anemia because of inhibition of DHFR pathway in the patient. So you have to know about this. Then second drug we are going to discuss is on the thiazolone. Thiazolone mechanism of action is inhibition of the cyclopropionation. This word is very important. Cyclopropionation of mycolic acid. And this is a activating step actually. Mycolic acid, we call activation of mycolic acid by cyclopropionation. Then only they can be added to the cell wall and the cell wall will become stronger. So this cyclopropionation word is important because it's asked in exams multiple times. At least in 2013 and 15, 2 times they have asked the cyclopropionation word. So let us know about that. And it's also a static drug. That's why we are seeing here. And it has a very, very poor activity against Mycobacterium tuberculosis, even though some activity has been demonstrated against some other bacteria, but very poor activity against Mycobacterium tuberculosis. It's proven activity, but very poor activity. We don't generally use this drug. At the same time, it is contraindicated in HIV patients. This point is again very important. I expect this point in the exam. Why it's contraindicated in HIV patients? Because of very, very high risk of fatal skin reactions. And that happens especially in HIV patients. We don't know the exact reason why, even though a lot of hypotheses are there, but there is no exact reason why it's producing these fatal skin reactions, especially in HIV patients. Fatal skin reactions. Very, very important point. Very poor active drug. Currently, we don't prefer this drug at all. Then we have ethionamide. Ethionamide, the mechanism of action is very, very similar to isoniazid. That's why there is some cross resistance to isoniazid, especially in patients who are having mutations of INHA. Clear? Remember, this drug need not get activated. Very important, because I told you INH has to be activated by CATG, then only it will inhibit the keto-enol reductase enzyme. But this drug directly inhibits the keto-enol reductase, which means CATG mutations are not going to affect ethionamide. But INHA mutations, which means increased production of this keto-enol reductase, might result in some cross resistance and problems with the action of ethionamide also, because the mechanism of action is very similar to isoniazid, acting on the keto-enol reductase enzyme. So especially mutations of INHA will result in some cross resistance, not entirely, but some cross resistance to ethionamide also. Or here I can write cross resistance to INH as well as ethionamide. And we all know this is a static drug, that's why I'm writing in this particular area. At the same time, the side effects we have to know. The side effects again is very similar to isoniazid. Hepatotoxicity, definitive side effect, then optic neuritis. Like INH, optic neuritis can be seen, but again, like INH, this optic neuritis is less likely compared to that of what ethambutol is going to cause. Ethambutol is the drug you have to know for exams for optic neuritis. So if you want to know all the 3 drugs that cause optic neuritis among all the ATTs, that is ethambutol, then isoniazid, and it's like relatively similar drug called ethionamide. So these 3 drugs are the ones that are going to produce optic neuritis in among all the anti-tubercular drugs. And they can also produce hypothyroidism. Very important side effect. This is not seen with isoniazid usually. That is hypothyroidism. And very importantly, peripheral neuropathy is not a significant side effect here compared to that of INH. In INH, peripheral neuropathy is very important, but here it's not that important. So I think with this we can complete this particular section, because I have discussed in and out and all the important points about all the anti-tubercular drugs and their pharmacology, important pharmacokinetic points, everything we have discussed, whatever is important for the exam. So mostly your questions will be revolving around this particular things, whatever I've told in this video. With this, we can finish off this and we can move to the next section, that will be the guidelines for how to manage TB according to the current RNTCP guidelines that are published in 2017 National Strategic Plan for 2017 to 25. So we'll see in the next video.